Hello, this is Dr. Erik Pedersen. We are going to go through case 9222. This is a companion case to cases 9220 and 9221. This is a CT angiogram of the neck performed on a stroke patient. So please view this in the context, starting with case 9220, then 9221, and then this 9222. So we're going to go through basically my approach to reading CT angiograms of the neck, and then we're going to talk about the pertinent findings in this particular case in a patient who's having left-sided stroke symptoms. So this is our standard CT angiogram of the neck. We've got a couple of sets of axial reconstructions here. This is a set of thin axial images that's typically about 0.6 millimeters thick. It's volumetric data, and that's what we're going to do the heavy lifting on. We've got some slightly thicker maximum intensity projection axial reconstructions here. We've got straight coronal reconstruction here, straight sagittal reconstruction over here, and then we've got oblique sagittal reconstructions that the technologist has tried to go through the plane of the carotid bifurcation. So we can see that area nicely on both the left and the right. So how do we start these? Well, I start with the aortic arch. So we go to the very bottom slice of the study, and here's the ascending aorta, here's the descending aorta. You can see the main pulmonary artery here with the right and left pulmonary arteries. And I basically follow the aortic arch up. And as you can see, the aortic arch is normal in caliber and contour. It does have some scattered atherosclerotic calcification at the margins, and that's okay. But there's no stenosis, no aneurysmal dilatation. Now, as we come up, you can see that we're starting to get the arch vessel origins. So remember that the normal configuration of the aortic arch, the first branch off of the arch is the right brachiocephalic artery, which is here, and that divides into the right subclavian artery, and then it also gives off the right common carotid artery. The next branch off the aortic arch is the left common carotid artery. And then the last branch in the typical configuration is the left subclavian artery. So what I do is I look at the right brachiocephalic artery. That looks like it's fine. I follow that all the way out to the right subclavian artery. We follow that all the way out here. We can see that it's widely patent and looks all right. And so now that we've cleared those, we're going to look at the left subclavian artery from its origin. There's a little bit of atherosclerotic irregularity here, but nothing that looks like it results in a significant focal stenosis. We're going to follow that all the way out. And again, it looks widely patent and quite nice. So now we're going to run the carotid. So normally I'd start with the right carotid, but that one's going to be abnormal in this case. So we'll start with the left carotid. And I basically go from the origin and we can follow it up. And so my arrow here is on the left common carotid artery. We're going superiorly. We've got a little bit of tortuosity. It takes some twists and some turns. And at some point here, quickly, we're going to run into the left carotid bifurcation right here. There's a little bit of atherosclerotic calcification at the left carotid bifurcation. And basically, it's going to divide into the left external carotid artery and the left internal carotid artery. So if we go to that nice reconstruction, that oblique sagittal reconstruction, here's that left side. You can see the left common carotid artery. Here's the bifurcation into the internal carotid artery and external carotid artery. Those two are easy to tell apart because the external carotid artery has a bunch of different branches, and the left internal carotid artery is an expressway all the way to the brain. It doesn't have any branches at all. So we're going to keep our focus on the left internal carotid artery as we work our way up here. Again, there's some more tortuosity. It takes a few twists and a few turns, but comes all the way up and goes into the skull base like it should, with no evidence of stenosis, no evidence of flow limiting dissection. So that left internal carotid artery system looks pretty normal, except for a little bit of atherosclerotic calcification at the bifurcation. All right, let's run the right side. So we're going to go all the way to the origin of the right common carotid artery. As we're coming up the right common carotid artery, things look pretty good. It's normally calibrating contour. We're going to follow it up here to the right carotid bifurcation. So here we are at the bifurcation. Here's the right external carotid artery and the right internal carotid artery. There is some irregularity at the origin and within the proximal right internal carotid artery, and then we come up and the right internal carotid artery just boom goes away, right? Here's external carotid artery branches on the right side, but if you look at this, it just comes up and stops. There's no contrast enhancement within this internal carotid artery, too much distal to its origin. And so if we're looking at the coronal reconstructions, you can see here's the bifurcation. There's a little bit of atherosclerotic calcification. This is external carotid artery with all of its branches. Here's internal carotid artery, and there's just this stump that basically stops right here. Again, here's our oblique sagittal reconstructions. Here's the external carotid artery on the right with its nice little branches coming off. If we follow up the internal carotid artery, it just comes up here and stops after this stump. So we have a right internal carotid artery occlusion, which is what we expected to see based on our CTA head findings. Okay, so obviously right ICA, very abnormal. Now we're going to run the vertebral arteries. The typical configuration for the vertebral arteries is they arise from the proximal subclavian arteries. So let's do the right side first. Here's right subclavian. Here's the origin of the right vertebral artery. The vertebral artery is going to come up. The V1 segment is where it's kind of in the supraclavicular region here. It turns into the V2 segment once we get into the transverse foramina, and we're going to watch this as it comes up here at the tip of the arrow. It's going to exit the transverse foramina into the V3 segment, come around the outside here, and then once it punches through the dura right here, it becomes the V4 segment of the right vertebral artery. Okay, so the right vertebral artery looks good. Let's follow the left vertebral artery down. We've got a little bit of atherosclerotic calcification in that V4 segment, but no stenosis. We're going to just follow it all the way around. We're going to come down the V3 segment into the V2 segment. And keep following it down at the tip of the arrow. It's a little bit of motion artifact that we're going to read through. We're going to follow this all the way down as it plugs into the left subclavian artery. So the verts are clear. And then the last thing we're going to do is look at the neck soft tissues. We're going to make sure that there's not some big giant mass in the thyroid gland or in the submandibular or parotid glands. We're going to look to make sure that the airway is patent. We don't have lymphadenopathy. We're going to look at the lung apices, throw that into kind of more of a lung window. We got a few ground glass opacities there that we don't care about too much in the neuro world. I want you to notice one of the incidental findings here. So this is the kind of left brachiocephalic vein. There's a little bit of gas in that vein. That's almost always from venipuncture or maybe a little bit of air in the injector. It's an incidental finding, and that'll get resorbed into the bloodstream over a short amount of time. So the impression here is occlusion of the right internal carotid artery from just distal to its origin, and then otherwise the neck vasculature looks good. Thanks for your attention.